It's a very exciting time for the CLL community, for the CLL doctors as well as for the CLL patients, because we have now new drugs that are already being used and also a lot of drugs that are being developed, and all of them seems to be very effective, less side effects, less long-term side effects, and easily taken as a tablet. And we are changing our concept of treating CLL. It's like treating hypertension. We take the drug, we control the hypertension, or we take the drug, we control the diabetes. And this is how we also do for leukemia. So it's an amazing time. What we were using to treat CLL patient, whether it was a newly diagnosed patient or patient with relapsed disease, is using a combination of monoclonal antibody with chemotherapy, what we call the chemoimmune therapy. And we could choose between different types of chemoimmune regimens, whether we want to give a more aggressive treatment and to achieve a longer remission period, or whether we use a lighter chemoimmune regimen and we don't want to put the patient who is frail into dangers or in complications. Now, currently, when we were able to understand how the biology of the CLL cells itself and the new drugs that are targeting only the CLL cells have been developed. So we are moving into an era when we are trying to give more and more targeted therapy, which will attack only the leukemic cells and not all the dividing cells that we have in our bodies. That's an advantage because we don't attack healthy cells. And the chemotherapy, if we give it, it might have long-term complications that we want to avoid because we are hurting or other cells and not only the leukemia cells.
So we're looking at a future without chemotherapy?
Well, it's hard to answer. There's a lot of clinical trials who compares whether we give chemotherapy or chemoimmune therapy or we give the novel agents, which are biological agents, and they are chemotherapy-free. And we have signals already that have been presented that there is an advantage giving chemotherapy-free regimen. But the long-term follow-up is about 5 to 7 years. It depends on the drugs. So we don't know exactly the long-term complication of the novel agents. Well, one of them is avoiding long-term complications because we know that the chemotherapy may hurt the DNA of each cell in the body, and patients might develop secondary malignancy after they got chemotherapy. And the novel agents that we are using now are tablets. Yeah. So patient doesn't have to come to the hospital to get an intravenous injection. They can take it at home, and they are being only controlled once every 3 months or 4 months just to see how the blood counts are. Yeah. So it's chemotherapy-free and also all doctor-free because they are more independent. Yeah. Definitely no. Definitely no. I mean, it's a hard topic because we call it wait and watch, the W&W, and the patient call it wait and worried. Because every time this W&W, it's not only wait and watch, because every time they come to clinic, they are afraid that I'm going to say, now we are going to start treatment, because they are very anxious.
So why not start treating?
So why not start treatment? Because still we know that we have for the ibrutinib 8% of probability to develop atrial fibrillation, and another % of patient will have aggravation of hypertension. And we have the more bleeding tendencies. And for the venetoclax, we have the risk for tumor lysis syndrome. So these drugs are not free of side effects. So we still don't want to put patient who doesn't need treatment at the risk of getting these side effects. Yeah, we have signals. I mean, we know, for example, that patient with 17p deletion shouldn't get chemoimmunotherapy because it won't work. They will be refractory to the chemotherapy. We know that patients with 11q deletion, which are typically present with bulky lymphadenopathy, they respond very well to a combination with chemoimmunotherapy, but also to the novel agent. We know that patient with trisomy 12 maybe doesn't need to get the monoclonal antibody anti-CD20. So we are starting to have more and more information how to tailor each group of CLL patient the best treatment. 17p deletion, it's a genetic alteration that the CLL cell might acquire. It's not only in CLL. All other hematological malignancy, others leukemia, multiple myeloma, may acquire this genetic change. And in this zone of the DNA, there is the gene for the p53, which is the most important tumor suppressor gene. So when we lose this tumor suppressor gene, we have a more aggressive disease. And this patient usually do not respond to chemotherapy, and we need to choose for them novel agent regimen.
So what is that? What is novel agent?
So now currently we have available 2 drugs that we know that both of them are effective for 17p deletion, but not only. For all the CLL patients, one is the ibrutinib or the Imbruvica, the other one is the venetoclax, and we are now learning whether we need to use one of them, both of them, to add them a monoclonal antibody, what would be the best combination, and also one of the most important questions is the duration of therapy. Do we need to give treatment for life, or can we give it only for a given period of time? So these are all questions that are being explored currently. Well, it seems that now when we are giving treatment which is tablets and we see less infections and less hospitalization due to infections, quality of life is getting better for the patients. And this is also being studied in the clinical trial when we measure the quality of life of patients, and we see improvement in the quality of life of patients in the era of the new drugs.